Hi, I'm Payman Sanati, and I'm a craniofacial surgery fellow at the University of Washington and Seattle Children's Hospital. And I'm here with Dr. Irene Mathijssen, who is the head of the Department of Plastic Surgery and professor of craniofacial anomalies at Erasmus University Medical Center and Sophia Children's Hospital in Rotterdam. Dr. Mathijssen, thank you for joining us today.
Glad to participate.
Our discussion today will be about non-syndromic craniosynostosis, and we wanted to get your perspective on it. Dr. Mathijssen, we're honored to have you today. To start off our discussion, what do you think has been some of the largest paradigm shifts in your career in the care of patients with non-syndromic craniosynostosis?
I think the biggest achievements that we made is introducing minimal invasive surgery, and that, of course, specifically relates to the sagittal synostosis. I think that really made a big change. It reduced the time in hospital, lessened blood loss, lessened the amount of blood transfusion as a result. And it's so much nicer for the patient. So I think that's one of the biggest achievements in this field.
Absolutely. And, thinking about how far we've come in the last few years with management for non-syndromic synostosis and looking at where we are now, what do you think are our current biggest challenges that we're facing as a surgical field for taking care of these patients?
The main issue for surgeons nowadays should be to really present long-term outcomes. Because I think still these days we still present a short-term outcome, and I think we're past that. So we should really be presenting outcome in patients that are at least like 10 years of age, and then present how are they actually doing, how they look, but also how their functioning is on school, in social behavior, and things like that. I think that should be really the next step in outcome assessment, so we can decide better on what treatment to choose in the young age.
And with these challenges in mind, where do you think we're headed in the future? What excites you about the new innovations that we're doing and the research that we're doing to advance the care of these patients?
Well, I think actually the biggest challenge for metopic synostosis is the big question, what do we add with surgery, and do we actually add anything? And I think it's still an option that we don't add anything, only putting these patients to some risks with surgery, giving them scars, making the parents worry a lot about all these surgical interventions. And perhaps we do not add anything, not in the way they look, not in their neurocognitive development, and not for their visual outcome. And it's now difficult to really prove that we don't need to do surgery when everyone is so customized with having surgery done. So it's almost being back 40 years ago and trying to convince people that it's perhaps not requested for all these types of metopic synostosis.
Yeah, you bring up a very strong point. It's been really fascinating to me to read your papers and look at the research that you're doing in Rotterdam. I'm excited to hear more about the work that you've done and hear what the newest innovations are that you guys are doing for these patients. Can you tell us a little bit of what insights you might share with us in the upcoming meeting here in Seattle?
Of course, I'd be happy to. So what we try to first point out is that the increased risk for raised intracranial pressure is not at all elevated for this condition. But of course, these are in patients that were operated on. So now we have to first prove that if I don't do surgery, that I will not elevate this risk, that it will remain as low as it is. On the other hand, a big part of the patients that do get surgery for metopic synostosis still have a poorer intellectual outcome assessment compared to their normal age children. We think that the surgery does not improve their neurocognitive functioning. But again, I have to prove that it will not be even worse without surgery. And so we did so far studies using MRI studies that really look into the microarchitecture of your brain with DTI studies, but also looking at the perfusion of your brain. And that is with ASL studies. And so far, all outcomes were completely normal between healthy children and metopic synostosis children. So slowly we're proving our point that there's not so much wrong with these children. And I think the most striking observation is that if you look at the parents, usually one of both has hypothyroidism, has a narrow forehead, but is just not aware of it. And if you look into their photos on childhood, they actually look like trichinocephaly patients. So there's probably a tendency for nature to be self-limiting, which is completely different than with sagittal synostosis, because if you have unoperated adult patients with a sagittal synostosis, you will still recognize them, especially with a baldness that occurs in these mainly male patients. They can still ask for correction at a later age. And I never encountered an adult that said, I'm so worried about the shape of my forehead and I wish I had surgery as a child. Because it just smoothens down by itself, is my belief. So, but I need to prove it. I know that some are do not accept this, and I think they're quite right. I first have to prove it.
Yeah, it's such an interesting topic and such a hot topic for our upcoming meeting. I look forward to hearing from you and your team here in Seattle, and also hearing from the other teams from around the country who may disagree and have a nice discussion about this topic when we all get together once again in a few months.
That would be very interesting. Looking very much forward to meeting you.
Absolutely. Thank you, Dr. Mathijssen. Thank you for joining us for our discussion.
Thank you so much.